about high-risk medication use in geriatric trauma populations. So here are my objectives for this presentation. First, it will be to identify high-risk medications utilized in the geriatric population, prioritize home medications to be continued on admission, develop a safe medication plan for patients during hospital stay, and evaluate medications at discharge. So a little bit of background epidemiology. The proportion of geriatric population is continually increasing. 1 in 5 Americans are believed to be older than 65 by the year of 2030, which is around 70 million people. And because of that, it increases the strain on our healthcare resources. You have more people with more medications, more chronic health conditions. They're coming to the hospital or going to see their physician more often. On the note of chronic conditions, nearly 2/3 of geriatric patients have at least 2 chronic conditions. And because of that, we get into this issue known as polypharmacy. And so depending on where you look, polypharmacy can be defined different ways, but for the purposes of this presentation, polypharmacy is when a patient's on at least 5 medications at the same time. And so I've kind of painted a diagram of how polypharmacy can happen. So a patient is prescribed a statin for their elevated cholesterol. They're on the statin for a little while, and then they go back to the doctor because they were having muscle pain. And so they are put on cyclobenzaprine for muscle pain. And then a few months go by, and the patient's having difficulty sleeping from the muscle pain, and so they're put on zolpidem. And so as you can see, there's a cascade of where instead of maybe in the first place, the statin could have been changed from a more lipophilic to a more hydrophilic statin that has less side effects. More and more medications are added and to cover side effects of the original medication, if that makes sense. Next, I'll address some drug-related problems in geriatric patients. The first thing we want to think about are adverse drug effects, especially your additive effects. So specifically, we look at benzodiazepines and opioids. Together, you can see a lot of respiratory depression in these patients, so it's something to be considerate about. A lot of the drugs that I'll be addressing today have multiple drug-drug interactions, but specifically as a class, tricyclic antidepressants have many drug-drug interactions. You're looking at cardiac function, seizure threshold, anticholinergic activity with those medications. And then physiologic changes. So our geriatric patients, typically as patients age, they have decreased major organ function, which leads to altered pharmacokinetics and pharmacodynamics. Patients can see decreased clearance, whether that's metabolism through their liver or excretion through their kidney, and that can increase the half-life of medications. Just for an example, digoxin under normal renal function, half-life is around 1 to 2 days, but in patients with impaired renal function, the half-life can be extended up to 3 to 5 days. So it's always important to consider major organ function. And then changes in volume of distribution is also an issue. As patients age, their body mass changes, their muscle mass decreases, they have less volume or more volume of distribution, depending on the situation where medication exposure can be changed. And then also patients can experience altered sensitivity, so they may be more sensitive to a medication at a lower dose. So that's something to be considered, especially with these medications that have high-risk adverse effects. Another issue with drug-related problems is inappropriate prescribing. So according to data, up to 37% of geriatric patients take 1 or more potentially inappropriate medication, and that kind of goes back to the diagram I painted earlier, where multiple medications are added for side effects rather than the primary problem being addressed, if that makes sense. And then on the other end of the spectrum, there's underuse that can occur, and this is specifically looking at the START criteria, which I'll get into a little more in depth later. But sometimes patients can have medications added to their regimen that need to be added based on their cardiac or their renal function or their like their status of diabetes. But I'll get into the specifics of that later in the presentation. So now I'm going to talk a little bit about the literature review that I've done as far as medication reconciliation in geriatric trauma patients. So the first study I'd like to talk about looked at geriatric patients over the age of 65 that were admitted to a trauma service. And then this is kind of how they selected their patients. So they looked at patients that were over 75 years of age, admitted to the trauma service, and then they identified patients who were over the age of 65 who had at least a TBI or post-concussive syndrome, at least 2 rib fractures, pulmonary contusion, pneumothorax or hemothorax, blunt chest injury or hemoperitoneum, pelvic fracture, long bone fracture, or spinal fracture with or without deficits. And then they looked at their past medical history to see if they had chronic renal failure, or they're on anticoagulants at home, cardiac disease, chronic liver failure, pulmonary disease, or obesity or diabetes mellitus. And so part of this study, they developed a protocol based on the ACS TQIP guidelines for geriatric trauma patients to look at the geriatric consultation service and see where medications could be addressed. So this is a image of kind of what the protocol looks like, and I really like how it shows how each team has a specific task and they work together to complete kind of this checklist over on the right-hand side of the screen. So looking at geriatric patients' pain control, making sure you're limiting their narcotic use using Tylenol, minimizing polypharmacy, and making sure that every medication has an appropriate indication and it has a purpose on their medication list. Getting them back on their essential home medications is very important. Accessing their activities of daily living, looking at their advanced directives and addressing any psychosocial issues. And each part of the team plays a role in completing this checklist. So the trauma team, the geriatrics team, nutrition, pharmacy, all of us play a role in making sure that this checklist is complete. And for this study, they identified that with patients with geriatric consult, they actually had a 75% reduction in the likelihood of being discharged on an inappropriate medication. So that kind of shows that this protocol may be useful. The next study I'd like to talk about was a case control study that looked at patients who were admitted to a trauma service. They were over 65 years old, and they were specifically patients who were identified to have a low risk of complication based on TQIP. And so patients who had a complication were cases, and patients who had no complication were controls. And the complications that they looked at specifically were pneumonia, unplanned intubation, unplanned ICU admission, and unplanned return to the OR. And then of those patients, they looked at different patient-specific factors and different criteria to assess whether or not, or they looked at basically what kind of correlation they could find to patient-specific factors or events that could have led to complication. And so this chart specifically looks at some of the non-modifiable patient factors that they looked at. The ones that I've boxed in were shown to increase the risk of complication. So patients who were on a home beta blocker and home anticoagulation were at a 2 times risk for developing a complication, whereas patients with diabetes or dementia or COPD were not quite at double the risk, but they still had an elevated risk for complication. And of note, patients who received a geriatric consultation were at a lower risk of complication. And so some of the key points I highlighted, but another one too is that there was no association in the admitting service and risk of complication. And then the last study I wanted to highlight was a medication reconciliation study. They looked at patients who were over the age of 15 admitted for trauma. Their initial medication history was obtained by the trauma team, which included general surgery residents, attending trauma surgeons, nurse practitioners, and nurse case managers. And then once that information was obtained, an admission nurse tried to obtain more information or verify that information. Once the admission nurse looked at the patient's medications and documented as much as possible, a clinical pharmacist was utilized as the standard to make sure that all the medications were documented appropriately and accurately. So they were comparing the accuracy of the medication history list by the trauma healthcare providers and the admission nurse to that of a clinical pharmacist. And so this chart, I wanted to highlight the amount of percent correctness that medications were obtained. And so TT here stands for trauma team and AN stands for admission nurse. And then they looked at the name of the medication, the strength, the route, and the frequency. And so for the medication name, the trauma team and admission nurse were both relatively around 60% as far as percent correctness. For the strength, you see a little bit of the dip in the trauma team at 19%, where the admission nurse is still 47%. The trauma team medication route was around 7% correct, whereas the medication route for admission nurse was near 60%. And then frequency, the trauma team was 16% correct, and admission nurse was 52% correct, which you would expect as the trauma team being the first people to see the patient. They may be intubated or they may not have quite the amount of time that the admission nurse or the pharmacist would have to document the information. And so this just kind of shows the difference in the trauma team, admission nurse, and the pharmacist. The study also documented some of the preventable errors that reached the patient. So, for example, multiple insulins were given despite the patient only taking one insulin at home. There are several incorrect medications given based on the strength that was listed or the name of the medication that was listed or duplicate therapies listed. And even medications from previous admissions were given that were incorrect. So that just kind of emphasizes how important it is that to utilize your resources for medication history, and that pharmacists can play a big role in helping making sure that the medications are appropriate and documented correctly. So in summary, for the literature review, there's a paucity in literature on this topic. It's not a very well-studied and well-documented topic, but of the literature that does exist, we see that geriatric consultation can decrease the likelihood of high-risk medication use. It can protect against complications, and that pharmacists can play an important role, especially in assessment of medication history. And so now I'll talk a little bit more specifically about the medications that we'll be looking at and assessing those medications. So the first criteria that looks at high-risk medications called the Beers criteria. It's endorsed by the American Geriatric Society and targeted for adults 65 years or older. And every 3 years they take a comprehensive, systematic, and evidence-based review of all the literature that's been documented and released on different adverse events, updates on new medications, updates on old medications, any other drug-related problems that have been studied over the past 3 years. And then they publish it. And overall, the language for the Beers criteria is more coming from a preventative standpoint. They really talk about preventing adverse drug events before they happen, and they take a very hard and fast stance on whether or not you should avoid medications or recommending alternatives. The stop-start criteria is less popular, especially here in the States, because it's mainly used and developed in Europe. It's very similar to the Beers criteria in that the stop criteria focuses more on that prevention of adverse drug events and lists those high-risk medications that maybe we should consider taking a look at, whereas the START criteria focuses more on starting medications that are underutilized. And they specifically break down medications by class. So for cardiovascular disease, making sure that patients are on appropriate antihypertensives or beta blockers. For respiratory disease, making sure they have adequate COPD control with inhalers or other therapies. And then for endocrine, making sure that their blood sugar is controlled, that they may tolerate metformin if that's a consideration, or being on an ACE inhibitor or an angiotensin receptor blocker for renal protective purposes. And so when we think about utilizing the Beers criteria, like I said, those are recommendations, not necessarily hard and fast rules. They kind of just list the adverse effects that you would see from medications and say avoid or not avoid or what to do. But potentially inappropriate does not necessarily mean definitely inappropriate. And it should be a place for us to start a comprehensive review of each medication that's on their profile that may be high risk. And understanding why medications are included in the criteria, most of them have really negative adverse effects like dizziness, confusion, altered mental status, increasing the risk of falls. So understanding why each medication is included in the criteria is very important when you're assessing medications. And then considering your alternative therapy, so utilizing your non-pharmacologic therapy. For instance, with patients who are at risk for delirium, we know that medications don't always prove beneficial. So utilizing, getting them out of bed, making sure their sleep-wake cycle is normalized are things to consider when you're thinking about non-pharm. Safer pharmacologic therapy may not necessarily be changing the drug itself, but utilizing a lower dose of the drug that you're thinking about using, and utilizing the minimum effective dose. As I mentioned earlier, that patients can be more sensitive to medications, so utilizing the minimum effective dose can be a consideration. So when we're thinking about assessment of these medications, the first thing that I think about is geriatric consultation. It's recommended by ACS-TQIP guidelines. There's several different protocols that have been developed at different places that utilize geriatric consultation, but just focusing on utilizing all of your resources to make sure that each patient has every problem addressed, every medication addressed. And then we think about medication history and using an interdisciplinary focus on medication reconciliation. So here we have nurses and pharmacy technicians that typically will do the medication history. Eventually you may have a pharmacist that helps you and you may not. So understanding when and where and how to utilize your resources to get a medication history and making sure that medication history is accurate and timely is very important. And then targeting your high-risk geriatric patients, so looking at those patients who are on multiple medications, looking and making sure that they're on or not on specific high-risk medications, and then addressing their medication reconciliation status. So has their medication history been done? Are we still waiting on something? And then addressing medications at each phase of care. So when they go from the unit to surgery and back to the unit, there are medications that may be used in surgery that aren't necessarily used in the unit. So making sure that the MAR is very clean and appropriate as patients change from unit to surgery to floor, and addressing medications specific to those phases of care. And when we're talking about assessing and monitoring drug therapy, making sure that the indication is appropriate, looking at the risks versus the benefits of using the medications, utilizing your criteria, whether it's Beers or stop-start criteria, and then addressing whether the medication is for an acute instance or used chronically. And then ultimately, we want to develop a safe and effective medication plan utilizing all of the factors that I mentioned previously, looking at the patient's clinical status, and looking at each medication's specific characteristics can be very important when we're thinking about preventing adverse outcomes. So I have a little patient case activity, so I just want you to take a minute and look at the medication list and try to identify which of these medications you would consider as high risk. And you don't have to answer, just think of it. Okay. So if you guess the bottom half of the list, then you would be correct. And we'll talk about each medication specifically later on in the presentation. For the purposes of this presentation, I will be addressing these specific medication classes as they will be included in a study that we're doing here at Erlanger, and I'll talk a little more about our specific study at the end of the presentation. But I'll be addressing anticholinergics, antiemetics, tricyclic antidepressants, sedative, hypnotics, anxiolytics, and skeletal muscle relaxants. These medications have been identified as ones that we see very commonly in this population, so we feel like this would be the most impactful group of medications for us to focus on at this time. And so for our anticholinergics, typically they're used for an allergic reaction, motion sickness, itching, or nausea or vomiting. They block your H1 histamine receptors, and because of that, they have a lot of negative adverse effects. So you see dry mouth, dizziness, blurred vision, constipation, urinary retention, and altered mental status. And a combination of all of these adverse effects with a patient who is at increased risk for some of these adverse effects can lead the patient to be at increased risk of falls or increased risk of confusion. So because of that, the Bierce criteria recommends to avoid the use. Some alternatives that you could think of are utilizing your second-gen antihistamines such as cetirizine or loratadine. You could also think about utilizing a low dose of these medications as you may be able to elicit an effect while utilizing a lower dose than you would typically see. For antiemetics, they're typically used for nausea, vomiting. They also block H1 histamine and muscarinic receptors. Of note, prochlorperazine has more dopamine antagonist activity than promethazine, and so prochlorperazine historically has been considered an atypical antipsychotic, so you may see more kind of muscle rigidity and muscular symptoms versus utilizing promethazine. And so if you're going to pick one of these medications from this list, pick promethazine. Adverse effects of these medications are very similar to that of anticholinergics. So you see the same increased risk of falls and confusion, altered mental status. So because of that, the Bierce criteria recommends avoiding the use of these medications. Some alternatives you could think of consider stopping the offending agent that's causing their nausea or vomiting, or utilizing a medication like Zofran, which can be more beneficial as far as side effects go, but you have to watch for QT prolongation. For our tricyclic antidepressants, they're typically used for depression, migraine, and chronic headaches and neuropathic pain. They block absorption of serotonin and norepinephrine. Their adverse effects are dose-related, so typically the higher dose you see, the more adverse effects you see. Mostly anticholinergic effects are seen with these medications, but they can also decrease the seizure threshold and increase your cardiovascular risk by causing arrhythmias and QT prolongation. They have a very high risk of overdose and have a very high risk of withdrawal at a very low threshold, so it's very important to consider that. Bierce criteria recommends avoiding. However, some alternatives for long-term use are utilizing your selective serotonin reuptake inhibitors or your serotonin norepinephrine reuptake inhibitor, or SNRIs. Drug of choice typically in this population for SSRIs would be sertraline. It has mostly the best side effect profile of those medications. And then duloxetine can be very beneficial, especially in patients with neuropathy. It has beneficial effects in patients who have neuropathic pain. And if these medications are going to be continued in the hospital, and that should be very considered, especially with the increased risk of withdrawal and seizures, utilizing a lower dose than what they're on at home can be appropriate as well. For sedative, hypnotic, and anxiolytics, they're typically utilized for those indications as well as seizure and alcohol withdrawal. They bind to our GABA receptors in the CNS and increase GABA receptor inhibitory activity. They can cause some cognitive impairment, delirium, and falls, and they have a high risk for withdrawal as well. The Beers criteria recommends avoiding the use, but typically these medications can be restarted on hospital admission, especially if you're worried about a patient withdrawing from them, or they may have alcohol withdrawals, or they may be on these long-term. So it's important to consider that when you're looking at a medication history. I highlighted these medications in the top left of this chart because all benzodiazepines are metabolized by the liver. However, these medications are your lot benzodiazepines, lorazepam, oxazepam, and temazepam, don't have active metabolites, and so your other benzodiazepines that have active metabolites can last much longer in the system, especially in patients who have altered major organ function. Some alternatives long-term for these medications could include, for anxiety, you can use buspirone, as well as SSRIs and SNRIs, and for sedation, trazodone would be more preferred than starting these medications. For our skeletal muscle relaxants, they're typically utilized for muscle spasms. Of note, cyclobenzaprine is very similar in structure to tricyclic antidepressant, so it acts centrally and acts on alpha and gamma motor neurons. But overall, as a class, these medications act as CNS depressants and sedatives. And so because of that, you see high sedation, high risk of fall and dizziness, and with cyclobenzaprine specifically, you see a lot of anticholinergic effects as well. Beers criteria says not to use them, but however, you can utilize for muscle spasms. Tizanidine is a newer muscle relaxer that's not on the Beers criteria, that has less prevalent side effects. And then if they're experiencing pain, you can use Tylenol or ibuprofen.
So is there an advantage of Robaxin over Flexeril? Use a lot of Robaxin.
Yeah, the main advantage would be the or the lack of anticholinergic side effects with Robaxin versus Flexeril.
And it comes IV.
And it comes IV.
Well, I haven't seen anybody write for Flexeril in a while. I think Robaxin has taken over. It's why. On that note, can you tolerate an intermission?
Yeah. It's a good time for intermission, so go ahead. Yeah.
Say only 7% got the route of medication right?
Yeah.
So, I mean, if you just guessed oral for everything,
Well, you also have to think
are
about.
people taking a lot more suppositories than we realize? where are they putting their food?
I don't know.
We don't know about what.
The point is,
7% correct.
it's not a full medication if you don't have those route frequency. So, I can't tell you how many times what is going to cause a arrival medication list, and there are like, it'll just say the medication name and straight, but then nothing else. So then there won't be like any route, any frequency.
You need these patients in the ER. I'll just put them to whatever
whatever you can fit it in. I mean, really, that study wasn't the best. I mean, they utilized pharmacists as the standard. So everything the pharmacist said was correct.
We are the winners.
Oh yeah, I heard you talking about that the other day.
Or you don't have like a table of don't use this, use these instead.
Yeah. No, not. I mean, Buspirone faster than SSRIs, but like in a.
Are we talking days? Are we talking minutes?
Not minutes. Yeah.
So people,
Don't use an SSRI if a patient's seizing.
you have to like encourage people just to take
Yeah. How long and how much they've been using?
if they would otherwise withdraw from an admin, they would otherwise withdraw, we should wean them off of that.
They've been on it for a while.
I was making shit up on writing it out. You just have to write it out.
Oh, our paper?
Probably.
Oh yeah, we made up all sorts of papers.
Make sure you give him a taper. Okay.
Just make sure you type in taper. Two different things. You should be able to do this. And take care of it.
I think everybody has gotten that piece that you'd like to continue.
Okay.
You'll find what you guys eat while you
No, that's okay. I'll get some after. Okay. So next I'll focus a little more on the idea of delirium. I mentioned it a little with benzodiazepines, but delirium is something that we really want to think about, especially in our ICU patients. It's very common. Up to half to 60% of ICU patients can experience delirium. And on that note, the PADIS guidelines say that modifiable risk factors include benzodiazepine use and blood transfusions. Non-modifiable risk factors being age, dementia, prior coma, pre-ICU emergency trauma or surgery, and then increasing Apache and ASA scores. Delirium is assessed with a validated tool called the CAM-ICU. And then delirium in the ICU is strongly associated with cognitive impairment post-ICU discharge, and it can be associated with longer hospital stay. So it's very important to consider delirium when you're utilizing benzodiazepines. And so this study looked at lorazepam as an independent risk factor for patients developing delirium. And so in this graph on the right, as you can see, the minute you use a dose of lorazepam, you go to 60% or 0.6 probability of developing delirium. And that risk or probability increases exponentially as you use lorazepam, reaching 100% around a 20 milligram cumulative dose. So even a dose of lorazepam can be a risk factor for developing delirium. And then another study looked at the impact of restarting home medications, specifically neuropsychiatric medications, on delirium and sedation outcomes. So as you can see, the white bars are the patients who were started on their neuropsychiatric meds earlier, whereas the black are patients who were started late. As you can see, the black bars tend to have a higher percentage as time goes on, whereas the patients who were started early developed delirium less. So getting those neuropsychiatric medications started early is very important when we're thinking about preventing delirium. So back to our patient case, the first thing I want to talk about are medications that you would consider restarting in the hospital. And so I'll go through each medication and kind of talk about the different questions you may ask yourself when you're thinking about restarting. The first one being the Crestor. Generally, you would think that this medication is pretty benign, and it is, and so typically you would restart it, but for patients who are in rhabdomyolysis or shock liver or hepatic injury, statins are typically metabolized through the liver, so you don't want to restart that if their liver is not working or if they're in rhabdomyolysis. For metformin, typically in the unit, we won't really use metformin specifically because it has an interaction with contrast. You have to hold it and worry about holding it, especially with patients with AKI. You worry about lactic acidosis. And so typically with short-acting insulin or long-acting insulin can be utilized instead of metformin until the patient's stable, going home or back on the floor. Lisinopril is something you may want to restart if your patient's blood pressure is elevated, but if you have an altered MAP goal like patients with spinal cord injury, you may want to consider. So thinking about the patient's clinical status before you start their blood pressure medication is very important. Citalopram, typically you want to start neuropsychiatric medications early, as I mentioned in the previous study, but you have to watch specifically with citalopram for QT prolongation. So those are questions you would want to ask yourself before you start citalopram. Diazepam, or specifically any medication that has PRN, but I'll speak to diazepam for now. Medications with PRNs on their instructions, you would want to ask yourself, well, how often is this patient taking this medication? How often are they refilling it at their pharmacy? And you can't always believe what the patient tells you. For instance, with the diazepam, you can check the CSMD And if the patient's saying they're not taking it that much, but they're filling it every single month on the day, that's something really important to consider when you're thinking about restarting their diazepam, and maybe starting them at a lower dose, or utilizing a different agent than diazepam, since it has so many active metabolites. Utilizing your lot benzodiazepines may be more appropriate than utilizing diazepam. Hydroxyzine and promethazine and methocarbamol all pretty much have the same questions you would ask yourself. Is the patient actually taking these medications? Were they left on their med rec from a previous admission? How often is the patient utilizing these medications, or are they necessary? For zolpidem, it would be similar to looking at diazepam. It's a controlled substance, so it would be on the CSMD, but you also want to consider how often the patient's utilizing it. Typically, they're only supposed to be used short-term, although that's not typically what we will see. So just thinking about how often the patient's using it, and if there's alternatives you could use for sleep versus hypnotic. And then lastly, their amitriptyline. It's very important to think about this medication when a patient is admitted. So if the patient's actively seizing or their QT is severely prolonged, that's something you want to think about before utilizing amitriptyline. But you could also think about utilizing a lower dose than what they use at home. So if they're taking 50 milligrams at home, you could maybe use 25 or 10 milligrams instead to prevent them from withdrawing from the medication. And then utilizing your alternatives long term. And I ask a similar question: which of these medications would you modify at discharge? If this is what the medication list looked like at discharge, does the patient need to go home on 10 milligrams as needed of diazepam? Do they need all of these PRN medications, or were they left on the MAR from when they went from the unit to the floor and they haven't been taking them for a week? Those are things you want to ask yourself before discharging patients on these medications. So last, I'll talk a little bit about discharge, and then specifically our study that we're doing here. So assessing the medications at discharge, you want to look at the risk versus benefit of chronic use of those medications, discontinue unnecessary medications if at all possible, and then design a safe and effective plan to modify the dose of potentially inappropriate medications. So making certain medications PRN versus scheduled may decrease the likelihood of a patient taking a medication around the clock, or adding a taper or a stop date to the medication, or making the medication with no refills so that the patient has to have that medication addressed if they want more of it. Are ideas to consider. And then simplifying medication regimens is always important. So especially in geriatric patients, medication regimens, the more you add on, the more complicated they can get. So looking at whether or not it needs to be taken once a day or twice a day, and choosing maybe an alternative medication that they only have to take once a day could be something to think about. Addressing discharge summary and documentation, making sure that the patient understands what they're being discharged on, that the instructions are very clear and appropriate for the patient, and then having that communication with the primary care physician, putting the documentation in the AVS can be very important for addressing high-risk medications at discharge. And so finally, I'll talk a little bit about the study we're doing here. So we as a pharmacy are including patients over 65 years of age admitted to the trauma service. We're specifically looking at high-risk medications at home. Our primary outcome is potentially inappropriate medications on admission at discharge. And so for each patient that qualifies, we will be completing a medication history and making recommendations based on the patient's clinical status and their home medications. And so we've been doing this week, but we'll leave a progress note in the patient's chart and directly communicate with the patient's primary team with our recommendations on what should be restarted, maybe held, or a dose modification. Once the patient has had their medication history completed, we will add documentation to their after visits. The primary care provider.
Is this just for trauma patients or all over?
Trauma. Does anybody have any questions specifically?
Corey, do you have see anything about Seroquel? It's a medication we use a lot here in the elderly that are sometimes mixed opinion that patients with mixed responses to.
Yeah, Seroquel can be risky, especially in your patients with documented dementia. Any medication like Seroquel, your antipsychotics, can increase the risk of death in patients with dementia. So it's very important to think about patients who have documented dementia as well as their cardiovascular function. Seroquel can increase the QT prolongation as well, so something to consider. No other questions? Oh, sorry.
How many folks are on your team to follow up?
Yeah, right now there's 4 or 5 of us, but we're recruiting pharmacy residents and pharmacists to help us with follow-up. Students too. Yes, ma'am.
I feel like one of the big eye troubles are when you take this more narcotics generally that you can write geriatric, especially on the top of it. Like when in the cave or see on the floor and you're trying to figure out which is that first one go, which ones are like the safest.
I'm not entirely sure of like Percocet versus Norco, which is safest. Typically, the lowest effective dose would be the way to go, and if at all possible, not utilizing a narcotic. But I understand, in trauma situations, it's not always possible. Yeah.
Should I be using that more for like refreshers?
I do not know.
So we pretty much use Robaxa across the board here because it's IV. So I think the important point to take away from this is a lot of these medications you may have to use in the short term. But don't discharge a patient with a month of Robaxin after they leave here from residential. So maybe a couple days after discharge if they weren't here for very long, but if they've been here for a couple weeks, I would not send them out with a script is the point. Hopefully they're at less risk of fall while they're here in the hospital, where they should be theoretically. Yeah. So, a lot of these medications, yeah, you're going to have somebody that's over 65 who has an allergic reaction and they need a dose of Benadryl, but don't prescribe Benadryl for sleep for these patients. So make sure that the reason you're giving it is appropriate, is kind of the key, and don't write long-term scripts after discharge.
Something I've been doing, I don't know if it's right to do with, I guess, over 65 or 70. I've been avoiding giving Pepsis to anybody. I don't know, PPIs.
Yeah.
Unless they're on a whole thing, but I try to not do that.
If they're eating not have to give it all.
Well, yeah.
Yeah, so there is some stuff that says that Pepsid can increase it, but there's more H2 selective and others not effective on H1. So typically I will change them off of Pepsid if they're starting to develop issues, but not everybody
precedent for it.
How do I feel about it?
Yeah. Again, agitation is probably the vendor of the recommendations.
I mean, it definitely has a better side effect profile versus a benzodiazepine. The most you would worry about is like cardiac, especially heart rate. It can lower their heart rate, but as far as it's more of light sedation versus your benzodiazepines are more heavy. So
The PADIS guidelines essentially say not to treat somebody's delirium with a pharmacologic agent unless they are at risk of harming themselves or others. So we emphasize non-pharmacologic treatment as much as we can, reorientation, make sure they've got their glasses, their hearing aids. But if they're, at risk of harming themselves or want to do so, then, short course of antipsychotics is appropriate. There's studies that have looked at the amount of people that get discharged on things like Seroquel who were not on Seroquel when they came into the hospital. And it was like, I think 30 to 40% of patients that got started on it in the hospital were discharged on it. So I think that's another important consideration. When the patient is no longer needing it, you need to be evaluating those meds on a daily basis to see if they are appropriate for a trial off of it.